This week's topic is going to deal with diabetes, and this is an incredible, complex, chronic condition. For the most part, it's a chronic condition that is imperative that exercise physiologists understand the pathophysiology of the disease, how exercise plays a really key role in therapeutic intervention, maintenance, and changes of blood glucose levels. So what I intend to go over is the benefits and risk of exercise for patients diagnosed with diabetes, guidelines, how to formulate an initial beginning exercise prescription, how to screen patients for diabetes, what are some of the fundamental assessment tools we want to be quantifying and noting, and how and when finger sticks, blood sugar levels should be checked, right? The frequency, the timing of checking glucose levels, and being able to monitor patients correctly while exercising. So we want to start with just the basics. Diabetes mellitus is usually going to be diagnosed as a chronic metabolic disease, but we want to think about it as an endocrine disorder, right? It's an endocrine disorder where there's insufficient amount of glucose or a lack of glucose secretion to metabolize carbohydrates. And it's changed the way we term the diagnosis. So in 1977, diagnosed is it's now characterized by etiology, and I'll explain a little bit more of that. Diabetes has evolved as we've learned more and as humans themselves have changed, right? So we'll talk about what's changed in our society with the disease. So again, it's really considered a chronic metabolic disease characterized by elevated plasma glucose levels. And we're looking at etiology and not age of onset. So again, we're going to look at etiology and not the age that somebody is at the time of diagnosis. So that's an important thing that we're to make sure we realize. So the beta cells of the islets of Langerhans are located in the pancreas gland, and they are really the core element that's responsible for secreting insulin, right? Insulin is a hormone that's required to metabolize carbohydrates. So what I want you to remember as we go through these slides is the concept of how do we get the sugar into the cells, right? That's what we're looking at, and that's what that protein, what I was saying about protein, that's a hormone, insulin, is at unlocking that cell to let that sugar go in. But what we see with diabetes mellitus is, remember, the etiology is what's going to give us the name. So type 1 diabetes, which is really called insulin-dependent diabetes mellitus. Previous classification of type 1, we used to call it juvenile diabetes or juvenile onset diabetes, meaning people get this when they're children. What happens, usually children through teens, the early 20s, kind of, in your youth, where the pancreas just stops working. Failure of the pancreas, little to no insulin at all is produced, and what happens inside the body is there's not enough insulin, and these are the people that will be taking insulin injections or using an insulin pump. Again, this once was called juvenile diabetes. Type 2 is what we spend most of our time in classrooms talking about, right? That is the core of what I want you to know for the assignment we're going to do this week is type 2 diabetes. Once was classified as non-insulin dependent diabetes mellitus. It used to be called adult onset diabetes. This usually was happening midlife and on. We no longer call it adult onset diabetes either. Remember, we're no longer classifying the labeling of the type of diabetes based on the age of onset, because what we're finding is more children are obese and sedentary that are ending up with type 2 diabetes, right? So the pancreas is still working. They now have what once was called adult onset diabetes, but due to increased adipose cells and increased sedentary lifestyle, our children have type 2 diabetes, which once, many decades ago, was really reserved for middle age and older. So those are the two we're going to spend our time talking about. Predominantly, we're looking at diabetes mellitus type 2. Gestational diabetes is a little bit different. But back to type 2 diabetes, again, common thing with type 2 diabetes is the body is producing insulin, but it somewhat failed to remember how to work. So we end up seeing ketosis, diet changes. They usually begin on oral hypoglycemic agent, oral medicine. They could end up on insulin injections if they need to. So if people are really non-compliant type 2, they could be taking insulin injections. But what we do notice is that those that exercise, they don't really need medicine for type 2. They should be able to regulate. They should, with diet and exercise, be able to somewhat regulate their diabetes without any type of pharmacological agent. Really, they're looking at glucose numbers. If the glucose is above 250, then we may know we're probably going to find some ketones in those urines. We're not going to let them exercise. We'll talk a little bit about these numbers in a little bit. Gestational diabetes is during pregnancy. We see this usually with older moms, more overweight moms. Once they have the baby, oftentimes gestational diabetes will subside, but only to usually come back again later on in life. So not ideal. Gestational diabetes puts the baby and the mother at a lot of multiple other risk factors. So this is a nice table that compares the types of diabetes with glycemia. Normal glycemic, hyperglycemic. So what you're noticing is, right, so non-insulin requiring, do you require insulin? What are the differences? And this will make more sense as we go through the lectures and we come back to this table. So when your body does not have insulin, we end up in a state of too much glucose. It's called hyperglycemia. Some of the common symptoms that people complain of is polyuria, large volumes of urine. They've got to pee a lot. Polydipsia, they're very thirsty. Polyphagia, increased hunger. Hemoconcentration, hypervolemia, hyperviscosity, hyperperfusion, and hypoxia. When you think about a lot of these, right, they're looking at the hemoconcentration. We end up seeing dehydration, increased plasma volume. With hypovolemia, we see increased volume fluid in the blood. Hyperviscosity is increased bleeding. Hypoperfusion is decreased blood flow into the organs. Acidosis is when you have low blood pH, and that can lead to death. You can put somebody can end up in a coma when you get to acidosis. Cosmological respirations are deep and labored breathing pattern that's often associated with very severe metabolic acidosis. Really, particularly, we're going to see cosmological respiration with diabetic acidosis, which is oftentimes abbreviated DKA, but also renal failure. So it's a really important form of what you see happening with hyperventilation, breathing increased above the normal rate, up there hypokalemia, low potassium. Really severe changes in the body happen when insulin is just not where it should be. So history with your diabetic patients is important. And again, this is geared to the exercise professional. This is all of you screening and learning somebody has type 2 diabetes. So a normal blood glucose range is going to be between 60 and 100, right? So 60 to 100 is normal. Fasting blood glucose test to be diagnosed with diabetes would be fasting tests with 2 tests that are greater than 126. So a perfect test question is, what is the glucose range that would be diagnosable to diagnose somebody with diabetes, right? Fasting blood glucose over 126 or greater, or an oral glucose tolerance test. So this is a test where they're not fasting, they're drinking a sugary solution, waiting 120 minutes, and then drawing their blood to watch how effective the body is at uptaking that glucose, and a glucose tolerance, an impaired glucose tolerance test that would give us the diagnosis of diabetes is greater than 200. Glycosylated hemoglobin test, or looking at serum proteins and albumin levels is another way. Most commonly, the number one is going to be a fasting blood glucose test. That's really classic, right? So fasting for a minimum of 4 hours, usually longer, and anything above 126. When they're looking at the urine levels, they're looking for ketones, renal function, and again, looking to see if there's any glucose in that urine. So that's peeing in the cup and taking a little stick and measuring. When you're looking at the clinical manifestations of diabetes, the 3 Ps that I just mentioned, right? So polyuria, polyphagia, polydipsia, those are really common. We see them occur when people end up with high levels of glucose, which is what we often see with people with type 2 diabetes, right? That's commonly what may end up bringing them into the doctor's office. Hypoglycemia, when someone gets really low sugar levels, they end up not feeling good. So and this sometimes, people without diabetes can end up feeling tired and weak and, diaphoretic, sweating, tremors, confusion, all of those things. So when you see somebody that's hypoglycemic, and we see this a lot during exercise, this will make more sense in a little bit, we want to treat immediately. So in most exercise facilities, the fast treatment would be a cup of water with diluted sugar packages in it, right? When you don't have orange juice on hand, we are going to just dilute some sugar into some water and give them some sugar water to drink. Immediately, we need to get those sugar levels elevated. It is sudden and dangerous. Why do we see hypoglycemia with exercise? Is as soon as those muscles start contracting, right? Muscles are working while the guy is exercising, it's eating up glucose, and that same body may already be taking insulin injections, that same body may already be on an oral agent, and that's combined with exercise could lead to dropping glucose levels. Right, so we know exercise can be used as a therapeutic intervention. If done properly and the person adheres to exercise, over multiple days a week and over weeks and weeks and weeks throughout the month, oftentimes they're going to need less insulin injections and less of the oral agent. So what is the difference between hyperglycemia, the symptoms of hyperglycemia, and the symptoms of hypoglycemia? This little cartoon is great, right? So your classic sign of type 1 is oftentimes a young child will start frequent urination. They're really hungry. They're not really gaining weight though, but their hunger increases. We see weight loss with type 1, fatigue, frequent infections, and a lot of times the parent, oftentimes teen years or younger. It could be into their 20s. I have had college students in my classes, a few of them diagnosed with type 1 while they were in college, but the symptoms don't often ring any bells until the child or young person is really ill, and then they end up going in and doing some blood work and realizing that the pancreas is now gone, right? Kind of gone, failed, broken. And again, they're now going to rely on an injectable source of insulin. When we're looking at type 2, remember this used to be called adult onset, but now we have our children in elementary school as young as 5, 6, 7 years of age that are overweight and sedentary having type 2 diabetes. With type 2 diabetes, they usually, some of the risk factors are living a sedentary lifestyle, familiar tendencies. So in the family, you see a lot of lines, many people in the same family having type 2, and it's not that it's a genetic, it's familiar. It's lifestyle based, the same bad diet, the same sitting on the butt too long, being sedentary. We once would say average age was 50 and above, but we know as a nation we've become fatter and somewhat lazier. So now we're seeing more type 2 diabetes. Fatigue, low energy, recurrent infection. So you see she's eating chocolate. She's got her hypertension medicine. She's got infections that aren't going to heal, right? So you can kind of get the gist of the kind of lifestyle she's living. With this lady, she is suffering from hypoglycemia. So the pathogenesis of type 2 diabetes is we're getting insulin out of the pancreas, but it's impaired. It's like the body doesn't remember how to utilize the insulin, right? It's very damaged. In the GI system, absorption of glucose is delayed. In the muscle, the person's sitting and sedentary and kind of lazy, a term I'm going to use, so that muscle is not uptaking the glucose like it should. So we have decreased insulin-stimulated glucose uptake. And then in the liver, increased basal hepatic glucose production is now happening. So it's a very big constellation of a mess with what's going on with insulin and glucose regulation. What happens with hyperglycemia, right? We got commonly those 3 Ps. We also end up seeing lots of other problems, right? Where the people aren't feeling good, they're putting at risk for a lot of other problems. Hyponatremia is a metabolic condition in which there's not enough salt and sodium in the body, and you can end up in kind of a confused state, kind of mental problems where you're not being able to focus. So the risk of injury-related hyperglycemia are the interventions are, number one, what are they eating? Right? Where are they getting their food sources from? What kind of carbohydrates are they eating? Are they measuring their blood glucose? Are they doing their finger stick monitoring? Are they on medicines? If they're giving medicines, are they taking them? That's the biggest question, is are they regularly taking them every day? So many people that are prescribed medicines and try to save money or try to self-medicate and alter, not taking the medicines when they should be with their oral treatment. When you're looking at oral treatment, for this class, I'm not going to ask you too much, but this is very important for those of you that are going to move on to a clinical setting, maybe aspire to be a diabetes educator. Sulfonylureas are first generation and second generation, right? This medicine, sulfonylurea agents, put us at higher risk for hypoglycemia. They work really well at lowering glucose levels, but the outcome is that they can drop the glucose levels so much that now they go too low. With the alpha glycoside inhibitors, that is another really common one. We have metformin, that's a classification under the biuanides. We've got a whole list of different types of medicines that on the slide here, these are the major classifications. All of them, they are going to work to lower glucose levels. These are all oral medicines, diabetes medicines that a person's going to take on a daily basis to try to get the body to uptake that glucose to lower their levels so they're not hypoglycemic anymore. So the key point when someone is on medicine, oral medicine, is you want to monitor their glucose levels, finger sticks. You want to teach patients the signs and symptoms of too high and too low. We want to really watch altered liver, renal function with the medicine, with the side effects that come from taking them. Over-the-counter medications are not going to be easily recommended. We really want to make sure that the over-the-counter medicine's not, depending on what's going on and what other prescribed medicine they're on, they oftentimes are contraindicated. Look for GI distress and sensitivity, and know the appropriate time to be taking the medicine. So when you think about taking the medicine and they're exercising and eating a meal, all needs to be done in like clockwork. So when they take their medicine, when during the day they're actually exercising, when the timing of their meals and their snacks, the more regulated we are, the better this is all going to be. So when someone takes an oral agent, that medicine, it has different ways in which it's going to work, right? So I mentioned the major classes. Look closely at this slide. The major classes of medicine are all listed under these arrows. And it's trying to help you to tell you or explain to you that different classifications of diabetes medicine is going to work a different way. So with glucose absorption, right, there is some alpha inhibitors that can happen. With peripheral update, trying to get the glucose to be uptake better through the skeletal muscle by looking at trying to increase insulin secretion from the pancreas by trying to slow down the hepatic glucose output. What I'm trying to explain here is with the pharmacological agents, it's all of the classifications are going to work within the system, the systemic system, on having a major or minor effect on the organ at changing how glucose is monitored or regulated. So the signs and symptoms, history, and physical exam are all things you want to ask. Talk with your client, right? So potential indicators for diabetes complication is if somebody has a high resting heart rate, or they've lost sensation and reflexes. Oftentimes that's going to happen in the lower extremity. You take a look at their feet. All of these people you are training, you need to take a look at their feet with their shoes and socks off, which sounds strange, but you need to do it. You're looking for any foot sores that are not healing, ulcers, excessive bruising. So those are your classic complications that oftentimes we want to be looking for. Anyone over the age of 45, we want to be screening. So more frequently, if somebody is overweight, so that would be 120% over desirable weight or just a BMI greater than 27. If they have a first degree relative with diabetes, they're a high-risk ethnic population. Any female that's delivered a baby bigger than 9 pounds, right? So if you are a 9-pound baby, your mother is at risk for type 2 diabetes down the road, right? Or if a female has gestational diabetes later on in life, they also need to be screened a lot more frequently for type 2 diabetes. Blood pressure levels, big link between hypertensive patients with diabetes, low HDL levels, high triglyceride levels, or previous impaired fasting glucose levels. So the American Diabetes Association is recommending that everyone over 45 be tested Be screened frequently for diabetes. So the diagnostic criteria, right? We know the casual, it's defined as any time of the day without regard to time of the last meal. You're taking a look at classic symptoms for diabetes, right? The polyuria, polydipsia, unexplained weight loss. So fasting is defined as no caloric intake for at least 8 hours. The test should be performed and administered, with kind of standard protocol. They do all blood work. And we're looking at glucose load, right? So you're looking at how much glucose load is in that blood. So criteria would be symptoms plus casual plasma glucose with concentrations greater than 100. That's with food in the system. Or fasting plasma blood glucose, as I mentioned earlier, 126 or higher, or someone who did a 2-hour a 2-hour plasma glucose test. So they drank the sugary solution, weighed it, and then they tested the blood glucose the blood glucose level greater than 200. So 3 different ways. Quite frankly, I think the one that you're probably most familiar with is going to be the fasting blood glucose greater than 126. On 2 occasions, going to be diagnosed. Now, here is a little bit of more information on you. So one thing that many of you might be familiar with is this A1C, right? Hemoglobin A1C. Our goal for all diabetics, everyone you train, is to get their tight glycemic control, right? So if you're looking for a goal to write for your diabetic clients, is to have tight glycemic control by adhering to regular aerobic exercise. And I want you to write down, my expectation is we can get your hemoglobin A1C to 7% or less. So hemoglobin A1C is that target for tight glycemic control. It's a kind of this magic number that physicians use where you do a blood draw, and over the course of weeks or months, it gives a glimpse to how many fluctuating glucose levels they had. So someone who has highs and lows, a lot of variability in their daily glucose, their hemoglobin level is going to be high, which is bad. Somebody who has tight glycemic control, they're following a good diet and they're exercising, they're not having sugar levels jump up and down all the time, they're going to have a lower hemoglobin A1C. The best news out of this lecture is exercise is a direct link to lowering your A1C levels, right? The more you move, the more the glucose, the sugar, is being absorbed in the bloodstream. Prenatal capillary plasma glucose levels, those should be between 70 and 130. So those are, taking a look at after you eat, where, preprandial is before you eat, your sugar levels should be between 70 and 130. Peak postprandial, which should be less than 180. And the blood pressure should be always, always, always less than 130/80, which I don't know if I've mentioned that in this class. So your healthy person, their blood pressure guidelines are lower than 140/90. Our hypertensive level for diabetics is 130/80. So we're looking at hemoglobin being less than 7. When you're looking at meals, before they eat, their glucose should be between 70 and 130. That's decent control. And then post-meal, it should never go anything above 180. Lipids, their bad cholesterol less than 100, triglycerides less than 50, and HDLs, we want those greater than 40. So this is an important slide for those of you that these numbers, might be new to you. Okay, improved insulin sensitivity happens with exercise. So why am I spending so many minutes in this lecture this week is because it is simply, exercise is a kind of this gold standard treatment for diabetes. The problem is most of the nation that has diabetes is not moving. The more you move, the insulin sensitivity is going to improve. We're going to have improved blood glucose control, reduction in insulin, need less insulin injected, and you're going to probably, over the weeks, need less milligrams of oral medicine because the muscles are playing a role in maintaining glucose. The muscles are contracting and eating the glucose, so we need less medicine. We also see decreased plasma insulin levels, improvement in glucose tolerance. And the key thing, again, is that hemoglobin level should lower as well, the A1C level. The problem with diabetes is the huge risk it puts on our body for other chronic conditions, primarily cardiovascular disease. So when you take a look at heart attacks or at myocardial infarction, 50% higher in males, and get this, 150% higher in females with diabetes. The death from cardiovascular disease is 2 times higher in males and 4 times higher in women. Heart disease, stroke, hypertension, peripheral vascular disease, all of these are at huge risk with diabetes. Why? Because elevated glucose is floating through those vessels, damaging systemic damage to how our body's able to fight off and ward off chronic diseases. Cardiac dysfunction happens, arrhythmias due to ischemic heart disease. Remember, I've mentioned, I think I don't mention this class, a lot of my classes have a lot of overlap, but people with diabetes end up with a lot of neuropathy, right? Where they have loss of sensation in their fingers, their balances could be off because of loss of neuropathy in their feet. The other thing happens when we talk about silent ischemia is neuropathy of the autonomic nervous system. You may never have heard of that. The autonomic nervous system is regulating symptoms. So if your heart is ischemic, not getting blood flow, your body is going to produce angina. It's going to say, help, right? These pain receptors are going to say, help, help. I'm not getting blood flow, therefore you have angina. But silent ischemia happens when the heart is being starved of oxygenated blood flow, but because of the autonomic nervous system being impaired, it's what we call silent ischemia. Their body is not producing classic heart disease symptoms. That is a very important thing when training somebody, exercise training somebody with diabetes. The other thing we see with diabetes is with autonomic neuropathy, right, is fluctuating blood pressure. So excessive rise and fall during exercise and heart rate. Again, same thing with a silent ischemia is autonomic nervous system is not sensing what it should, and therefore the hemodynamics are not as responsive as they should be. With diabetes or post-exercise, right, so once they're done working out, they are at high risk for orthostatic hypotension. It's just plummeting blood pressure. Again, why? Autonomic neuropathy. Cardiomyopathy, enlarged, weakened heart due to long-standing diabetes is another big thing. So medicine, right? They're going to be prescribed some type of medicine. Insulin therapy, there's many different types of insulin therapy when you're looking at insulin therapy. Short-acting, fast-acting, intermediate, all of these different types of insulin. When you're looking at actually how the insulin regimen, it could be a single daily injection, it could be 2, 3, 4 doses combination, lots of ways in which somebody may need to be taking insulin. This is a lot. I'm not going to go too deep into this, but for those of you that want to know more, there's way more information for the exercise professional and understanding how to become a diabetes educator. But this is showing you the kind of lifespan of insulin. So when you're taking a look at how long the insulin is going to act in the body before you need another dose, and where it happens between breakfast, lunch, dinner, sleeping, midnight, all of these, kind of a 24-hour around the clock is looking at how long that insulin sparing action is going to be left in the body. The other thing about insulin is we want to ask the person what type of insulin they are on, how many, what volume of insulin are they taking, the injection site. What we know about where they inject the insulin, in the butt, in the stomach, in the thigh, they want to rotate those sites. You want to rotate different sites. The absorption rate is going to change. Obviously, injecting the insulin, let's say into your thigh, and then you're going to go run, what's going to happen is that it's going to be uptaked too quickly. So we want to really understand different locations and what are the best locations. And that would be for, kind of level 2 diabetes lectures to be able to get into this a little deeper. The timing of the injection and mixing different types of insulin together. A lot of young people that are on insulin are often on a diabetes pump, right? You may have known someone that looks like a little pager and a little tube connected to them. And that helps them to constantly always know what their insulin levels are and what their need is. These are some of the classic insulin injection sites, but again, the site and the rotation of the site and what type of exercise program they're on is what we really want to be looking at. The complications of insulin therapy is something called lipoatrophy. Lipoatrophy is a term describing a localized loss of fat tissue. So this can occur as a result of subcutaneous injections of insulin in the treatment of diabetes from the use of what we know as human growth hormone or into those subcutaneous injections. The dawn phenomena is sometimes called the dawn effect. It is early morning, usually between 2 a.m. and 8 a.m. A high increased blood glucose level. It's different from what we call chronic smoggies. which is a rebound in that dawn phenomena, and that's really not associated with nocturnal hypoglycemia. So the dawn phenomena is caused by a release of counter-regulatory hormones such as cortisol, glucagon, epinephrine, all of which can signal the liver to release glucose. Other causes may include insufficient insulin administration the night before, incorrect medicine that they may be taking, or eating carbs before bedtime. So all of these just kind of show you taking a look at the timing, when they are, and then what their blood glucose levels are going to be. So the dawn phenomena, right? So the dawn phenomena is this red one, right? So the dawn phenomena can be managed in many patients by simply avoiding carbohydrate intake at bedtime, by adjusting the dose of the medicine or insulin, by switching to a different medicine, or by using an insulin pump to administer extra insulin early in the morning while they're sleeping. Most of the cases, there's really no need to change the insulin dosing of patients who encounter the dawn phenomena. A lot of times you're just altering their diet, what they're consuming. Alternative methods are continuous subcutaneous infusion, the insulin pumps. Lots of new devices are on the market right now. There's, the transdermal patch, inhaled insulin. There's all these different ways. The pump has really come a long way. It's used for most people I know with type 1 diabetes, athletes. You may know someone that yourself from high school that had an insulin pump and was playing sports, and it was really well regulated. Drugs that do not, oral medications that do not contribute to hypoglycemia are really nice, because then we're able to exercise them and not have the added effect of the oral agent that's also plummeting their glucose levels. Again, more drugs that don't contribute to hypoglycemia. Some of these you may see advertised on TV, especially Metformin. The drugs that may lead to more low glucose levels, right? So we've got a list of medicines. Again, I'm not going to ask you too much detail about a lot of these medicines, but I want you to look up. You ask every client, what medicines are you on? And then you go to the computer, you look them up, and you look for the effect. What effect will this medicine have when they exercise? And for diabetes, will this medicine lower their glucose levels? Will they have more hypoglycemia? So insulin is going to lower their glucose levels. Sulfonylureas are going to lower their glucose levels. So again, moving off of insulin and medicine, as I mentioned earlier at an earlier slide, you want to always inspect their feet, which is a little bit out of the realm of what you're used to doing, right? We're not in podiatry school, but we're going to be exercising them. They're going to be using their feet a lot. So what are you looking for? You're looking for any type of foot ulcers, especially when they tell you that they have neuropathy, funny feeling in their feet, their balance is off, orthopedic injuries that could be related to peripheral neuropathy, accelerated degenerative joint disease. For people that have foot ulcers, right, what they may look like. They can look pretty intense. And, this photo shows you, this is a classic neuropathic ulcer that the pressure points that happen. And guess what, guys? The people usually don't feel this. If they've got really bad neuropathy, they can't really feel this. And it's not healing, right? The part of the problem with diabetes is their wounds don't heal. So many of these patients, while you're exercising, need to be referred to a podiatrist. Podiatrists are great at dealing with all of this. They will clean the wound, they will pack the wound, they will tend to their feet, they'll trim their nails, they'll get everything situated. So podiatrists and diabetes are usually hand in hand. In the world of exercise, I talk about socks. I want a good quality sock, a sock that's just not a cotton sock that's going to get wet and soggy with sweat, right? You want a nice higher price sock that's going to wick that sweat away. I want their shoe to be a little bit bigger, half a size bigger, so there's a little room among impact and walking for that toe box to heal. So really important. So proper skincare and foot care, eyes, vision. Ask them how often are they getting their eyes tested. With diabetes, we see increased retinopathy, right? We call that diabetic retinopathy. So all those little vessels that give blood to our eyes get damaged, and we see very early onset vision problems. So diabetic neuropathy, diabetic retinopathy, diabetic nephropathy, diabetic gastroparesis, these are all super, super common with elevated glucose levels. So diet, education, fluids are super, super important. So the diabetic retinopathy vision is such a big, big deal. Once vision goes or balance goes, and blood pressure really needs to be well regulated. So important things to be thinking about. Again, complications: high sugar, hyperglycemic; low, hypoglycemic; diabetic acidosis, hypersmolar hyperglycemia. So when you're looking at the hypersmolar hyperglycemic non-chaotic syndrome, right? Just abbreviate HHNS, right? Serious condition most frequently seen in many times older people. It can happen to people earlier with type 1 or type 2, but occurs more often with type 2. It's usually brought on by something else, such as an illness or an infection. Blood sugar levels rise. The body tries to get rid of the excess blood sugar by doing what? Passing it into your urine, right? So really, what they end up seeing is too much insulin or too little glucose is really the cause of what we call diabetic acidosis. So this is potentially life-threatening complication. It happens, again, this one happens a lot of times with their diabetics type 1. But again, this diabetic acidosis can happen with type 2 diabetes under certain circumstances. So it's a shortage of insulin. The body responds and switches to burning fatty acids and producing acidic ketone bodies that cause very high level of symptoms. So diabetic acidosis, oftentimes the first symptom is underdiagnosed diabetes. They just don't know they have diabetes, and more time passes and damage happens. It also happens in people who have diabetes that have an illness or are not complying with insulin therapy. Symptoms could be vomiting, dehydration, gasping breaths, mental confusion. They can be put into a coma. How do we diagnose it? Looking at blood and urine. So really important. It is absolutely a medical emergency. Somebody can die from this. So, metabolizing fats for energy. The goal here is to lower glucose. Our goal is to get on medicine or insulin to get your glucose to be between 75 and 150. So the management of acidosis is by really sticking to the game plan so you don't have so much fluctuation. So smaller hyperglycemic non-chaotic coma is usually going to appear with dehydration. There's a lot with type 1, insulin secretion, no thirst is present, profound dehydration, but they're not thirsty. No polyuria, very severe hyperglycemia, and they usually are very lethargic, so really not safe. What I want you to know is that when someone has diabetes, their chronic complications, cardiovascular disease, as I mentioned, stroke, cerebral vascular disease, retinopathy with the vision, diabetic neuropathy, nephropathy, erectile dysfunction. So circulatory system, sensory into the optic nerve, the renal system, the nerve, the neurological symptoms, infection among patients. With exercise, this is just the golden treatment. I mean, I can't be any more excited to share with you the benefit of doing exercise with diabetes. You want to be consistent, the same amount of minutes, the same time of the day. Schedule exercise. It must be very, very regimented. Schedule exercise to take advantage of the postprandial hyperglycemia. So postprandials after they eat, high sugar levels. Exercising, however, late in the evening can increase the risk of nocturnal hypoglycemia, because what we see with exercise and diabetes is there's often a delay on when their glucose levels are going to drop. So they don't often drop right away, but a few hours after exercise. So if you exercise in the evening, they could be dead asleep when their glucose levels are dropping, and that's not safe because they're not going to be able to feel that, sense that. So I'm going to give you, again, more complications. So with retinopathy, you want to avoid any activities that are going to rise the blood pressure above systolic 170. So this is why we want to monitor our clients' blood pressure during exercise. We are not allowed, and this can be used, blood pressure can be used as a way to gauge exercise intensity for diabetes. You're used to using MET level or heart rate, but blood pressure is absolutely fine. You want to get them on a program where their systolic never gets higher than 170. Autonomic neuropathy, again, remind yourself what this is. Symptoms are silent, so they may not be able to feel their sugar levels dropping. They may not be able to feel angina. So we want to use the heart rate, the RPE scale, because their heart rate could be blunted, their blood pressure could be blunted. Impaired thermoregulation might be a new word for you. Thermoregulation is bodies that are unable to sweat to maintain core temperature. Which is an important thing to know, right? So we sweat to maintain our internal temperature, and with autonomic neuropathy, that switch is turned off most of the times or broken. Peripheral neuropathy is being careful of weight-bearing activity because of the peripheral system that has trauma to it. They can't feel it, they can't sense it. Nephropathy is you got to work at low levels, right? So we're looking at not increasing a high intensity. You want to make sure that when they're on dialysis, try to avoid exercise on the days you're on dialysis. Microvascular risk. So the higher the blood pressure, the more risk. So avoid exercises that involve straining, elevated blood pressure, Valsalva-like, holding your breath. You don't want anything that's going to affect those little vessels that lead into the eyes, right? Diabetic retinopathy. Nephropathy, it's spelled wrong. High intensity exercise is discouraged because of simply with you're looking at they're on dialysis, and we don't want to increase protein into proteinuria. Peripheral neuropathy, again, weight bearing, try to get them on a bike, on a rower, non-weight bearing exercises to try to lower the risk of weight bearing problems. So screen patients' knowledge, ask them how much, talk to them, ask them how much they know. Insulin and oral medicines, are they self-monitoring? Are they doing their own finger sticks? If so, are they logging them? Are they writing them down? Talk about their diet habits. How many meals are they eating? Are they reading labels? Do they understand basic nutrition? Talk with them. I feel so many exercise professionals just bypass food because they think like the diet police are going to come and sue them for talking about food. Guys, if you're exercising, ask, what kind of foods are you eating? What's your frequency of eating? What are your portion sizes you're eating? We're not prescribing a medical nutrition therapy, but you need to be helping them with understanding how to balance their intake, their meals with their exercise regimen. So screening their knowledge and talking a lot is an important thing. How we monitor is if we get an elevated glucose level, a FSBS, a finger stick, a little, machine that pokes the little drop of blood and you put it on the strip. If that's elevated, then often we're going to follow it up with a urine, right? Pee in the cup and test for ketones. All of diabetics should have some type of ID on them. So oftentimes it's going to be a diabetic bracelet because we know post-exercise hypoglycemia can really knock them out, and we want to immediately recognize if someone is diabetic, we need to get glucose into their system. Right, so we want to realize when you're doing basic first aid, if someone has got a bracelet that says they're diabetic, if we can get them some sugar intake, oftentimes, it's going to change the course of your first aid you're going to administer. So the purpose of diabetes is to control and lower glucose. That is why this lecture is so long, because it will have a direct link on lowering glucose levels. We also want to try to reduce the amount of insulin injection that they're going to need. Inspect their feet. Look for blisters and cuts. Wash the feet. Explain to them they have to dry their feet before they put their socks on. Moist feet after a shower are going to lead to more blisters and problems. Avoid bathing in extreme temperatures. Why? Because they can't feel the hot water, and that's going to do more damage to their nerves. Wear socks at night if they're cold. Their circulation is going to be bad. Their neuropathy is going to be bad. Not to walk around on barefoot in the summertime. They can't feel things. The hot surfaces is going to do more damage. Don't try to self-medicate. Send them to a podiatrist. Corns and calluses and all those stuff that you can buy at like the local pharmacy are not to be put on their feet. Do not put any adhesive tape on their feet either. Again, send them to a podiatrist. So inspect their shoes, look at where their weight bearing is on their feet. Don't soak their feet, apply baby oil if it's really dry on their feet. Wear properly fitted socks, as I mentioned before. Shoes should be comfortable. Leather shoes are going to be best. And never avoid, educating them to always have socks on, never go barefoot. No sandals with thongs between their toes. Wool socks are best. Wool socks are great, especially in the winter for warmth and sucking away the sweat. Toenails, calluses, most of the foot stuff, I'm telling you so much of this, so you tell them to go see a podiatrist to tend to them. When you're looking at neuropathy in patients, extreme care in their hands and their feet, many a times they're not going to be able to take their own pulse and their wrist because they can't feel. They've lost the neuropathy in their fingertips. We also often see abnormal pulses and blood pressure, again, because of autonomic neuropathy. So they might be wearing a heart rate monitor, using a hand sensor on one of the exercise machines, avoiding rapid position changes because with autonomic neuropathy, the body is not sensing those positional changes or even the need to increase or decrease heart rate. So exercise for the diabetic patient who's lost protective sensation, you may want to avoid, contraindicated, might want to avoid treadmill, prolonged walking, jogging, or stepping exercises. Why? Because they've got a lot of neuropathy. Maybe swimming, bike, rowing, chair exercises, arms, things that are non-weight bearing. That makes sense. So our goal is tight glycemic control. Remember the A1C, hemoglobin A1C level of 7% or less. Want to minimize complications. Weight. Weight is an important thing. We want to manage their weight. My goal is always weight maintenance. You're not allowed to gain any more weight. I know weight loss is tough, but at least set the goal that they're not allowed to gain weight, right? We want to maintain, if not, maybe lose 2 pounds per week. Little weight changes can have a dramatic difference on someone's medical outcome. So some physical therapists focus, or fitness trainers focus so much on weight loss, and others ignore it as if I'm not going to tend to it, I'm just going to make you happy. Guys, weight maintenance. Find their weight, set that goal, don't let them increase. Ideally, 2 pounds a week is ideal. If they don't lose, it's okay, but it's not okay to let them gain, and address that. So when you're looking at the guidelines, or exercise guidelines, cardiovascular, 40 to 85% of their heart rate reserve, 20 to 60 minutes. We are looking for 5 days with diabetics. The more they exercise, the more aerobic exercise, cardiovascular exercise they do, the better control their glucose is going to be. Resistance training and flexibility, just as you know. We want to avoid high impact with these patients, especially because of the neuropathy, especially with the systolic blood pressure. Our frequency, durational glycemic improvement is going to happen after the last bout of exercise. So that drop in blood glucose could be 12 hours after the exercise. It could be 72 hours. So what I want you to know is that I never want someone to go beyond 72 hours without exercising. So every day, at minimum every other day, simply because of the rebound effect of how long it takes to drop the glucose, and then the very next day you need to exercise again to maintain those nice low glucose levels. So within 3 days, right, if you go 3 days without exercise, you're going to begin losing the benefit of tight glycemic control that's happening post-exercise. Do not go no more than 72, ideally 48 hours without exercising. So the minimum threshold that we need to improve functional capacity, but below that, which elicits really undesirable responses. What in the heck does that mean? You need to find the sweet spot of intensity where it's just below being too much, but just above where it needs to be to start seeing some changes. The best way to do this is the talk test. Exert them where they can still carry on a little bit of a labored conversation. That usually is that sweet spot for the diabetic patient with exercise intensity. Higher exercise intensity for this class of patients is usually associated with higher risk. So sometimes a high intensity training program is great. A new diabetic is not. We want to be careful that we're not letting that systolic blood pressure and their glucose levels spike too much. Minimum 10 minutes or more, right? 700 to 2,000 calories per week. The range really needs to be a little in the beginning because we're looking for frequency, not necessarily volume in the beginning. We're looking for frequency of movement, get those muscles contracting to uptake the glucose. So it might be 2 or 3 short walks or 2 or 3, rides on their stationary cycle, 12 minutes, 15 minutes, 10 minutes, a couple times a day. Longer exercise may result in a higher incidence of course, injury, aches and pains, musculoskeletal complaints. So begin slow so they can slowly titrate up to their comfort with exercising. Finger sticks are an important thing with exercise. Those of you that go into a clinic setting, you're going to see finger sticks being done. So I want you to understand finger sticks. I want you to practice them, be aware of them. Most patients have the units, but they stop monitoring themselves. So patients' perception is, I have diabetes under control. They think they know they have it under control, but usually they don't. So what you want to do is test their finger sticks the first few weeks of an exercise program. It's going to provide the basics of getting some data, understanding the progress of how fast you're going to up their workloads. It's also going to help give us information to call back to their attending physician who's regulating their insulin or their oral medicines. So it's going to provide tangible feedback on if this client is going to be able to have a reduction in their oral medicines. So you need to know finger sticks. It's understood that clinical judgment should be considered. So we're looking at is that by doing finger sticks, we're able to have the conversation with the patient and calling their doctor and saying, I don't know if this insulin or oral medicine is right. I'm doing finger sticks with this guy 3-4 times a week on the fitness floor, and I'm getting these readings all over the place. And over the phone, oftentimes, that can be changed. We also want to really keep good logs of their food intake, and I ask patients to log their food. Logging food is great. Most of the fitness apps will have an ability to log food intake. Use it. Be aware of it. Look at their food log. Again, you're not a dietitian, but you're smart enough to realize the basics on the frequency. Are they eating? Are they following what they should? If you notice the food log, they're really skewed and not doing what they should, that's when we get an RD involved, right? That's when we're going to get the medical nutrition therapy going on. The timing of exercise must be somewhat the same. Early morning to the afternoon is usually a great time of when they should be exercising. Patients who are taking oral medicine or who are on insulin control for diabetes, I want you to be doing finger sticks for at least the first 6 exercise sessions at minimum. I want you to look at what their glucose is when they start and when they end exercising. I want you to write them down, and I want you to continue monitoring those finger sticks until you feel like the glucose is where it should be. So pre and post exercise finger sticks may contribute or may continue to be checked if you're seeing values that are really skewed. So if you're less than 90, those are too low. Greater than 300, those are too high. Right? So kind of understanding. So what do we do pre-exercise if someone comes in and their glucose is less than 100? Well, they're less than 100, we need to eat something. So what they're going to be eating if they're less than 100 is they should be ingesting 10 to 15 grams of a carbohydrate. Right? So we want to take a look at what that is. Carbohydrates, all of you should have basic nutrition understanding, but you want them to eat something which is a little counterintuitive in the world of exercise. We're not usually eating before we exercise. With diabetes, we need to keep the glucose where it needs to be. If it's greater than 100, don't eat anything. They're fine. But less than 100, less than 100, and they're going to do more moderate intensity, we're going to up the glucose intake. So about 30 to 45 grams of a carbohydrate. If it's less than 100 and the exercise is moderate intensity, long duration, eat a little bit more. So these are all the things you would learn if you sat for the diabetes education certification, the diabetes educator. When you're looking at carbohydrates, quick foods are something you can consume right away. So it could be cheese and crackers, it could be some peanut butter. These are all things that are going to be kind of that complex carbohydrate that's going to be ideal. Fruit, fruit with some carbs. If you're looking for quick acting, because it's really low and you need to get it up, then that could be fruit juice or a piece of hard candy, tablespoon of sugar or honey. If the opposite happens, they're above 250, we're going to have them pee in the cup and do a little, get the little dipstick and take a look if there's any ketones in there. If it's over 300, it doesn't matter what's going on. They are absolutely not allowed to exercise. Stop, call the doctor. Something is going on wrong. Either they're not following the rules, the patient isn't, or they're not medicated like they should be. So timing and dosing of medication and exercise needs to be balanced. We want to reduce postprandial hyperglycemia. So again, exercising after they eat is ideal. Blood glucose should be monitored after exercise session to determine the patient's response, and then continuing monitor until, again, you feel like the sugar levels or glucose levels are where they should be. Post-exercise. So counter-regulatory hormones with exercise can happen, as I've mentioned, right? Post-exercise, it may happen immediately, could happen many hours later. Less than 70 is what we call post-exercise hypoglycemia. It is pretty common. Want to monitor hours, for many hours following. You want to treat it as a medical emergency. They need to drink or eat some fast-acting glucose to get it up. Why this happens is poorly controlled. They're either on too little insulin, or these counter-regulatory hormones with exercise are coming into play. So that's causing the glucose production in the liver. It's enhanced free fatty acid release by the adipose tissue, reduced muscle uptake of the glucose. All of those things can cause what we call counter-regulatory hormones with exercise. The result is an increased blood sugar during and after exercise. High-intensity exercise can also result in hyperglycemia. Again, so slow, sustained intensity is in the beginning, going to be best until we figure out how the body responds. This is another adjustment based on blood glucose levels before and after exercise. So, depending on where it is, what they need to eat, and how long they need to wait before you retest. Again, it's a little foreign to be telling you we might need to be having your clients eat before they exercise, but if they're a really bad diabetic and very new to exercising, that's going to be within the scope of what we should be doing. When patterns of diabetes control show change, so either they're getting better or they're getting worse, you need to be contacting the physician, either you or working with the client or the patient. Physicians love getting data of what's the exercise program, or what is their glucose levels. Maybe you even have food diet. Maybe they're using an app, on MyFitnessPal app, and they're logging their food intake. So have them take personal responsibility and have them be logging. Managing their finger sticks pre and post exercise should absolutely be encouraged. So remember, potential hypoglycemic responses can be as late as 24 to 48 hours after an exercise session. Remember, you don't want them ever to go more than 48 or no more than 72 hours between exercise bouts. If a patient's finger sticks remains out of control, again, contact their PCP, their primary care physician, or whoever it is that's overseeing it. They could have an endocrinologist that's doing their diabetes. We want to get involved. What do you want to know about exercise? We know that you need to be giving them exercise 3, 5, 7 days a week. You're focusing on aerobic. The aerobic is going to activate a lot of skeletal muscle. The more skeletal muscle that's being activated and contracting, the more glucose is being uptake. So reasons for exercise, right? Define the need for insulin. If they're overweight, we're walking daily, moving daily for basic weight maintenance. Follow our type 2 diabetic diet plan, reduce calories, right? What's the purpose of exercise? To increase the transport of glucose into the muscle cells. We're not exercising if somebody is hyperglycemic, right? Or hypoglycemic. Storage and dose of preparation. If they're on insulin, where are they putting their syringes? Are they well educated on how to do their injections? Again, they're going to learn this through a diabetes educator, which all of you in the class would qualify in time to sit for that exam. And you want to be able to interpret those results. So the 5 components of diabetes management, which is again classic certified diabetes educators: what are they eating, right? Nutritional management. How are they exercising? Are they monitoring themselves? What type of pharmacological therapy are they on? And how well educated are they? So the triangle of diabetes management are, again, the things we're talking about: diet, exercise, medication. What is their glucose? Are they monitoring what's going on in their urine? Is there any ketones? It is a very complex disease. The best news about the complexity of this disease is I have worked with countless patients and clients myself where they have been able to eliminate the need for diabetes medicine simply because they have stuck to the diet and exercise plan. Predominantly, if they really get going with an exercise program, you will notice that they are slowly, over months, taking less and less milligrams away from their medicine they're taking. And this complex diagram is telling you just that, right? It's so incredible. So when you're looking at the exercise prescription, consider all of the things we talked about: retinopathy, microvascular disease, peripheral neuropathy, autonomic neuropathy, your delayed and blunted hemodynamic response. So many things to consider, right? So when you're looking at the mode, intensity, and frequency, walking is what most people want, and it's okay as long as their neuropathy is not going to bother them. Their feet are okay. Walking is okay. If their feet are bad, we're doing non-weight bearing. Intensity is going to be low and slow, nice and steady until you get a feel for their glucose response. 3 days is really too low. 5, 7 days is really what we want, but you can go as low as 3. Classic minutes, 150 minutes or more. Timing is everything, right? Try to keep everything nice and regulated. Resistance training is something we can do as long as they're not doing the Valsalva, as long as they're not like holding their breath. That's going to drive up their systolic blood pressure. Again, the reason for that is the small little vascular vessels that go to the eye with retinopathy. So you're classic. I think you all know the basics behind resistance training with your sets and your reps. Range of motion is another one with flexibility and basic range of motion. Neuromuscular training is another important thing, especially with aging diabetics, to help with balance and center of gravity. This is a great table that shows you cardiorespiratory strength, flexibility, and body composition. Just to review, what do you want to think about with your diabetic patient? What's going to happen with exercise? Exercise training is going to improve glucose control, especially our type 2s. With type 1, exercise is usually going to help them be healthier and live longer, but doesn't necessarily change the course of action of the disease. Type 2, the actual pathophysiology of how the insulin is uptake will change with exercise if they're compliant. Improved glucose tolerance seen as little as 7 consecutive days with subjects in type 2. Fast, that's fast change, guys. Insulin sensitivity in both skeletal muscles and adipose tissue can improve with or without changes in body composition. The effect of exercise on insulin action is lost within a few days. Beyond 48 hours with no exercise, they begin to lose all the benefit they had with doing the aerobic training session. 67% of our adults that are diabetics are also hypertensive. Remember that silent killer of hypertension, high blood pressure. Some control trials show reduction in blood pressure with exercise training, and some show no change at all. So research has shown some mixed results on training with change in lipid levels. Moderate weight loss significantly improves glucose control. It's okay if they can't drop 80 pounds. Can they drop 8 pounds, 10 pounds, 12 pounds? Of course they can, right? And yes, that's not the number they want to lose. They want to lose bigger, but that's enough to start seeing glucose levels and really predominantly systolic blood pressure levels change as well. So the epidemiology evidence supports the role that exercise has a huge role in preventing and regulating type 2 diabetes. Dealing with diabetes requires lots of dedication. It requires a lot of education. Patients must cope with complications, the threat of developing lots and lots of other risk factors and other complications. Exercise training of various types should be an essential component to the treatment. Physical activity can and has the ability to improve blood glucose control, lipid levels, cholesterol, blood pressure levels, body weight, and reduce stress.